Good evening, everyone. How are you all? Welcome to First Aid AMC MCQ free 2-week sessions again. So tonight we are going to discuss cardiology, right? So for cardiology, we take two classes in the free session, and then there is also another ECG class that we take in as part of the course class. So those are the three classes that we take for cardio, and we can cover most of the topics within that. So tonight you are going to learn a little bit more about how we take our theory session. And cardiology is one of the most important topic from medicine that comes in exam. So all of you need to have a very good knowledge on these medicine related topics because medicine carries the most marks or the highest number of questions come from medicine, right? So we're going to focus entirely on cardiology, but as part of cardiology, we are going to focus mainly on chest pain today. So before we go into that, so you are aware that this is part of our free 2-week session. And I understand many of you are here and you are already enrolled into the course. So just to give you an idea that the course has already started, you guys are doing the free 2-week sessions as part of the course because these classes don't get repeated. The course students are going to exactly have the same thing that you are having. Why we offer this is to give you an idea that how our course works, how the classes are going to be, so that you can have an informed consent to start preparing with us. And if you like how we are teaching you, if you like how we are showing our materials and everything, then I always say that go and enroll into the course because if you can if you can enjoy 2-week sessions with us, it means that you are going to enjoy the entire 5 months. So having trial classes are important. Not only that, that many of you will not be our students, but still this will help you to learn a lot about cardiology. This might be the start of your journey to Australia. There are students who come to us saying that, Doctor, I did your 2 weeks class from YouTube, and then I passed my exam. So that 2-week sessions was my start of my preparation, and I really felt confident. So I see people like that as well. So what I want you to say is this is the start of your journey to start preparing for AMC MCQ. And when you do it correctly. Study hard and make sure you try to give your best to prepare for this journey because the journey is not easy. It's never an easy thing because you are going to be a doctor in Australia. And to become a doctor in Australia, it's never going to be the super easy road, but you are taking that road, and your dream is to work here as a doctor someday. So prepare yourself for that day. And if it takes time, I'm sure it's worth it. And I know because I'm working in here, I know it's worth it. Okay. So I'll not waste any time tonight because there's a lot to discuss. So we'll move into cardiology from now. No, Dr. Purnama, the last class should be in the portal. It's in the portal in the recent in. So what was the last class we took? The the psychiatry, right? The tips and tricks. Sorry, the tips and tricks should be in the question solve discussion. Okay, so if you see the recent question solve and then if you search tips and tricks, it should be in the portal. All right, move on to cardiology tonight. So first of all, let's have a look to the video. Okay, so first thing from cardiology is to learn the basic. So before I go in there, I wanted to show you what are the research that we are going to follow for cardiology. So as you are aware that we follow John Murtagh ninth edition. So from John Murtagh ninth edition, these are your cardiology chapter. So in the cardiology chapter, chapter 30 is the most important chapter because it's the chest pain chapter. And then there are several others, including palpitation, heart failure, which we will discuss in our next cardiology class. We also take a lot of help from therapeutic guideline. This is really important. You don't need to subscribe for therapeutic guideline. It costs a lot, but the important topics will be discussed in the course anyway. We also take some help from Kaplan Step 2 CK. Then RSCGP guideline is always important for any medicine related topic. Like, let's say you are not sure about aortic stenosis. You want to know a little bit more about Australian guideline of aortic stenosis management. And you're not getting anything from anywhere because it's not even there in John Murtagh. So what you can do then, you just Google aortic stenosis Australian guideline, or you can even try to search aortic stenosis RSCGP guideline. And sometimes you will find few topics which you are trying to search for. Not everything is there in RSCGP guideline, but most of the important topics will be there, which is quite important. The lecture note will have almost anything that you need for cardiology, so you don't need to go into these things because everything is in the note. And also at the end of the cardiology, you can go into any Q bank and just solve some cardiology questions. That's how you start your preparation. When I say that we are doing cardiology, means that we are doing a cardiac theory. It's not about cardiac questions yet. First, you'll have a good basic. Once your basic is good, then you go to the Q bank, you solve questions. You don't bypass or you don't do the opposite, that you start the Q bank and then you come back and learn theory. It's not that way. You learn the theory first and then you go to a Q bank or any past questions. Just see that if you are getting the questions right. Okay, so it's for every topic that you are going to read. It should be first theory, and then you go to some either past recalls or you go to a Q bank, could be Amedex Q bank, M plus, any of the available Q bank, and then just solve some questions from there. Okay. Now, before we go to that, I want you to have a good basic about cardiac physiology, because without knowing physiology you can't actually understand the diseases. So I'm going to show you a video first and then I'll discuss how cardiac system works. So have a look on this video.
The normal heart has two sides, a right side and a left side, and four chambers: the top receiving chambers, or atrium, and the lower chambers, which are thick-walled pumping chambers, called ventricles. Red blood cell will come from either the superior vena cava or the inferior vena cava and enter into the right atrium. The blood then flows across the tricuspid valve to the right ventricle. The right ventricle then squeezes and ejects that blood cell into a vessel called the pulmonary artery. Pulmonary artery splits into two vessels, each going to the lungs. As that red blood cell makes its way through the lung, it returns through the pulmonary veins to the left atrium. That blood is now oxygenated. It's picked up oxygen, then goes across the mitral valve into the left ventricle, which does most of the work in terms of delivery of blood flow to the body. That blood cell is now ejected into the aorta to some organ or muscle or skin in the human body.
Okay, so that's the video of how the cardiac system works, right? Now, before we go into that, now I can see that many of you are asking questions that is not related to cardiology today. Please keep these kind of questions for the end of the class, because otherwise these classes we will never be able to finish anything. So tonight topic is cardiology. We'll focus mainly on cardiology. And at the end, if there is any general questions that you have, keep it for the end of the class. That way we can finish things that we really need to. Okay? All right. So let's have a look how cardiac system actually works. So if you say that this is your heart, you guys can hear well, right? I can see someone saying I can't hear. Yeah, you can hear well. Okay, let's move on. So this is your heart, and we know that heart has four chambers. We have got right atrium, left atrium, right ventricle, left ventricle. So blood will come from superior vena cava, and the superior vena cava means it's a venous system, so it will carry the blood from the upper extremity, which means it will carry the blood from the upper limbs and also head and neck. And then the inferior vena cava will carry blood from the lower legs or lower extremity, and all the venous blood will come into the right atrium. This venous blood are deoxygenated blood, right? Now, once everything is here, from the right atrium, blood will go into the right ventricle through the tricuspid valve. Okay? And then from the right ventricle, blood will then go to the lungs through the pulmonary artery. So for pulmonary artery, I'm just going to change the color so that it's easy for you to remember. And this is where we have got the pulmonary valve. Okay? So far, everything is deoxygenated. So from the right ventricle, deoxygenated blood will now pass through the pulmonary valve into the pulmonary artery. And through the pulmonary artery, blood will then go to the lungs. In the lungs, this deoxygenated blood will get oxygenated. How it get oxygenated? So if you know the physiology, then it will make sense. So we know that the end of all the bronchioles is the alveoli, right? So that's the end of our airway. And then we have got around the alveoli, we have got small tiny blood vessels, which are the capillaries. Now, these capillaries, because these are blood vessels, and what happens in here that through this pulmonary artery, the carbon dioxide, so this is still deoxygenated blood. This carbon dioxide through the alveolar capillary membrane, so this is the alveolar capillary membrane. Through this membrane, the carbon dioxide will then diffuse into the alveoli. And you know that we exhale carbon dioxide, right? So we are going to exhale this carbon dioxide out. And now when we inhale, we bring the oxygen into our lungs, and the oxygen will now go into this capillary. And this is where the oxygenation of the blood will happen. Again, so pulmonary artery carrying the deoxygenated blood, and then this is where the diffusion of air or diffusion of gas happens. So carbon dioxide will go into the alveoli and come out of your body, and the oxygen that you have inhaled, it will go into the artery, into the capillary, and then it becomes oxygenated. This oxygenated blood will then come into the left atrium through pulmonary vein. So through pulmonary vein, The oxygenated blood is now going into the left atrium. From left atrium, through the mitral valve, this blood will then go into the left ventricle. Right? So far clear, everyone? Your understanding? Very good. Okay, so from the left atrium, blood is then going into the left ventricle, and the valve that regulates this blood flow is the mitral valve. And then from the left ventricle, blood will now go into the rest of the body through the aorta. And the valve that controls that is the aortic valve. And that's how our heart works. That's how the cardiovascular system works. And this is the basic. If we don't understand this basic, we don't understand anything. Okay? So when heart contracts, the left ventricle pushes the blood into the aorta. This pushing of blood into the aorta or the contraction of the left ventricle is what we call systole. And when heart relaxes, then heart actually takes all the blood from the periphery. And that is what we call diastole. Okay? Does it make sense to everyone? You guys are nice and clear? Okay. If we understand this basic, then we can move on and we can start our preparation. Well, I don't know what's your name. I know that everyone has medical degrees, but I know a lot of you will not have this basic. So when we discuss something, we want to make sure that everyone is in the same page. Everyone, and this is okay because if I take 5 minutes and I discuss these things, it's going to help a lot in the rest of the class for people to understand what is systolic heart failure, what is diastolic heart failure, and what am I discussing. And these basics are important. And I'm sure not everyone have a clear idea about all of this. Okay? So if any of you don't like the basic, just mute and then come back when we discuss the main thing. That's really fine. Okay, let's start with the chest pain. So chest pain is the most important topic for cardiology. And every one of you will get some questions from cardiology, and most of you will get questions from chest pain. There's a lot of questions and there's a lot of confusion in here. So tonight we are going to solve those confusion and we are going to be in the same page so that it doesn't make us confused in the exam, because these are what we call mastery questions. And AMC never says what are the mastery questions and what are the most important questions. I don't know if it is a myth or not, but AMC has mastery questions, and those carries a high mark. And it's also kind of a double-edged sword, because if you miss that question, the chance of getting pass is very low. So there is a set criteria that a candidate needs to get at least most of the mastery questions right. And the mastery questions means the questions which everyone with a medical degree, everyone with a they're being a doctor, they should know the answer of it, like how to manage chest pain. That's everyone should know, because life and death is there. Because a patient with chest pain, if the doctor doesn't know what to do, that patient will be dead. So there are some mastery questions which AMC has, and we assume that chest pain is definitely part of the mastery questions. So when a patient comes to us with chest pain, When a patient comes to us with chest pain, what are the differential diagnoses that we have? So first of all, we need to know about cardiology, like there are cardiac causes of chest pain, there are respiratory causes of chest pain, then GIT causes, musculoskeletal, neurological, and vascular. As part of cardiac cause, angina is the most common cause, and then myocardial infarction, could be pericarditis, could be mitral valve prolapse. This is usually the most common cardiac causes of chest pain. Vascular aortic dissection is very important to rule out. Respiratory, pulmonary embolism, pneumonia, pneumothorax, and lung cancer. But these three is the most common cause. But how to differentiate a cardiac chest pain with a respiratory chest pain? That's when you need to know the characteristic of the chest pain. A cardiac chest pain, especially if it is ischemic heart disease or MI or angina, the chest pain will be heavy, pressured. It feels like constricting. So that's when we think of cardiac chest pain, heavy, constricting, and pressure. And in case of respiratory cause of chest pain, the pain what they usually describe is called pleuritic chest pain. So sometimes even by looking at the chest pain characteristic, we have a very good idea that is it coming from the heart or the lungs. Pleuritic chest pain is a sharp pain and the pain will get worse with inspiration. So the pain that gets worse with inspiration or deep breathing, that's what we call pleuritic chest pain. So almost all of them, pulmonary embolism, pneumonia, pneumothorax, they will have a pleuritic chest pain. Then we have gastrointestinal. In the gastrointestinal system, the most important thing to rule out is esophagitis. And also we will be ruling out peptic ulcer disease. These are not that important, but we will discuss that in the GIT system. But mainly, if we're looking for a chest pain, and the chest pain which comes from gastrointestinal system, the patient will complain that it's a burning chest pain, burning central chest pain, and they will almost always have heartburn. There will be acidic brush, which means acidic or metallic taste in their mouth, and they will have a lot of reflux, burping, belching. So then we think of GIT cause of chest pain. Musculoskeletal chest pain, many times we see this kind of patients, and that's very common to have a musculoskeletal chest pain. So they go to gym and then they do a lot of heavy lifting and they come to us with chest pain. That's just entirely just muscular strain causing the chest pain. That's very common. Sometimes after having a trauma, motor vehicle accident, they can have a fracture rib, which can cause the same thing. Costochondritis, there is a condition which is called Tidje syndrome or costochondritis, where the costal cartilage, where it connects with the rib cage, that costochondral junction will get swollen and tender. This is the one most common cause where if you press on the costochondral junction, that will be tender. Almost any other causes of chest pain, it will never be tender to touch. But when you touch a specific part of the chest and it is tender to touch, then we think of costochondritis, especially if it is on the costochondral junction. Definitely fracture rib will also be tender, but that's not always in the costochondral junction, right? But if it's tender on the costochondral junction, then that is what we call costochondritis. Neurological, which is herpes zoster, they will definitely have a rash. So that's very easy not to miss, right? So these are the most common causes of chest pain. This is from John Murtagh. You can go through that in your own time, but we covered almost all of them. So we're now talking about few causes of chest pain. So we are talking about aortic dissection. What is the characteristic of aortic dissection pain? So this comes in exam, and you need to know the characteristic of the pain to come to the right diagnosis. So aortic dissection, the pain patient will say is the sudden, severe, sharp, tearing kind of chest pain. And very important clue is that the chest pain will radiate to the back. All right. And then there are a lot of other things that they will have, but we are not going into that yet because I will discuss these things later on anyway. But right now I'm focusing on the characteristic of the pain. So sudden, severe central chest pain, and it's kind of a sharp tearing which radiates to the back. That's what is the characteristic of the aortic dissection chest pain. Then there is pulmonary embolism. Pulmonary embolism is not a cardiac cause, it's a respiratory cause of chest pain. The patient will have a pleuritic chest pain. So the pain that gets worse with inspiration, deep breathing. Along with chest pain, this patient will also have dyspnea, so acute shortness of breath. They also have tachycardia, so their heart rate will be elevated, their respiratory rate will be elevated, so tachycardia, tachypnea, and also oxygen saturation will be low. And most importantly, pulmonary embolism usually have a risk factor. So they will give you in the exam, in the question, that patient went for a long travel, long flight, did not walk at all. The entire flight, patient slept. So what happened is that they formed a DVT in the leg, and then a emboli has dislodged, and now that has blocked the pulmonary artery, causing the pulmonary embolism. So there is usually most of the time there is a cause of having a clot in the lung, okay, which is what we call as provoked cause or provoked DVT. So if we know a cause that's provoked, if we don't know a cause and patient just end up having an embolism, that's unprovoked. But most of the time we can relate to something causing this. So pulmonary embolism is not the discussion we are going to have today. It's going to be a part of respiratory system. We'll discuss a lot about it because it's a very important topic. But right now, all you need to know is the symptoms of it. Coming to pericarditis. Pericarditis is a different kind of cardiac pain. This is a pain which is actually pleuritic pain. So this is one of the cardiac cause of pain which is pleuritic in nature. So patient will say sharp left-sided chest pain, and the pain get worse with inspiration, deep breathing, also get worse with cough. But it will get better with leaning forward, but it will get worse with lying down. If you auscultate the heart, you might get a pericardial rub, and most of the time you get a recent viral illness in this patient, which is causing the pericarditis. So it's preceded by viral illness, but the type of the pain is sharp, stabbing kind of chest pain, and the pain is pleuritic in nature, which means it gets worse with deep breath, cough, and it's positional. That means when patient lies down, the pain gets worse, but when they lean forward, pain gets better. Now, for stable, let's say now we're talking about angina. Angina is part of ischemic heart disease, which means that this patient having some kind of coronary artery blockage. And this is the main essence of tonight's class. So first of all, we divide the ischemic heart disease into different types: stable angina, unstable angina, and then you have myocardial infarction. But the quality of chest pain is same. The chest pain for ischemic heart disease will be described by the patient as tightness, heaviness, pressure. Sometimes they can have epigastric pain as well. So middle-aged or elderly patient having a sudden onset of epigastric pain do not rule out myocardial infarction. Okay, always make sure you do an ECG to rule out acute MI in a patient who is middle-aged or elderly having a sudden epigastric pain. Nausea, vomiting can be associated with MI, and patient can also have dizziness, fainting, and excessive sweating. All right, so we will come into the stable, unstable angina later on, but right now all we know is the characteristic of the chest pain. So this is a very good flow chart of all the pain. So we know that costochondritis pain will be reproduced if you palpate the chest wall. That means it will be tender to touch. We know peptic ulcer, the pain will be in the epigastric region, which will be mainly worse after eating. And others we know that myocardial infarction, pain will last for more than 20 minutes. And pericarditis we know. Okay, so this we already discussed. Same chest wall tenderness will be there in costochondritis. If the pain radiates to the back, it's aortic dissection. If pain worse with lying, better when sitting up, that's pericarditis. Bad taste in the mouth and patient having a lot of reflux, then we think of gastroesophageal reflux. Sudden onset dyspnea, tachycardia, hypoxia, pulmonary embolism. So first of all, understand the main presentation of each of these conditions so that when you read the question, your mind clicks that, yes, this is what I know about this case. Okay. Now, this entire thing we are discussing from Kaplan step to CK, I'm only discussing the things that is only important for you, not everything. All right, so far we learned about the chest pain, that how the chest pain looks like in different scenarios. Pain in pericarditis. So pericarditis pain is sharp, stabbing, central, and the pain will get worse with lying down, and pain will get better when they lean forward. Yeah, so Karim, why pericarditis pain changes? Especially when you lie down, then the cardiac layer or the pericardium usually contracts or rub each other more, okay, than when you are leaning forward. Now, let's say we have got a patient with a chest pain. What is our initial investigation of choice? Any patient who has a chest pain, our initial investigation is always ECG. And if someone doesn't know that, then definitely he or she should not pass AMC. So this is, now remember, this will be tested. It looks very simple, but still people miss this. So any patient who has chest pain, ECG is our initial test almost always. Now, if a patient has chest pain and ECG is normal, can you be fully sure that this patient doesn't have any heart attack or doesn't have myocardial infarction? No, we can't. So one, that sometimes ECG changes are dynamic changes. That means at the moment, just within 1 hour of having a chest pain, the changes that you are seeing, that ECG might change in the next couple of hours. So in a patient with myocardial infarction, the ECG changes. So single ECG, patient is still having a chest pain, it's not enough to rule out anything. Any patient whose chest pain is lasting more than 20 minutes, you can't just do one ECG and if it is normal, send the patient back home. You can't. You have to wait. You have to do repeat ECG. You have to do cardiac enzyme. So that's when we have the cardiac enzymes, because it's not always we will get a ST elevated MI. We can get a non-ST elevated MI as well, which is the subendocardial myocardial infarction. So the essence of understanding this is that a patient who has ongoing chest pain, if the ECG comes normal, definitely you need to add a troponin. Let's say in the first 1 hour, ECG is normal and cardiac troponin is also normal, but patient still have chest pain. What will you do next? Can the patient go home? No, patient can't go home. So you will need to wait for at least 4 to 6 hours if the patient has ongoing chest pain. So usually you will need to do multiple repeated ECG and troponin. So you have to do repeat ECG, see that if there is any changes happening, and at the same time you will need to do the troponin. First is ECG and then troponin. Okay. Now, while we are discussing about the cardiac enzymes, there are several cardiac enzymes that we can order, so we have CKMB, we have cardiac troponins, and we have myoglobin. We no longer use these things. So myoglobin, CKMB is not used anymore in Australia. If we suspect myocardial infarction, we will go to troponin. But still, it's something that we should know. So for troponin to become abnormal, it takes 4 to 6 hours after the chest pain. That's why we are doing the repeat. Within 1 hour, troponin still can be normal because it takes 4 to 6 hours to become abnormal. So troponin, it will take at least 4 to 6 hours to become abnormal, and it will stay abnormal for 10 to 14 days. Whereas CKMB, same timing, 4 to 6 hours to become abnormal, but it will get better within 1 to 2 days. All right. That's why we say that if a patient has got myocardial infarction and then you treated the patient, and then after treatment, within a week, patient again got severe chest pain. At that time, which test you will mostly rely on? Yes, that is the time. So if we want to rule out reinfarction in the same patient in the same time period, that's the time we are going to rely on CKMB. The reason is that CKMB will get better within 1 to 2 days, but troponin can stay elevated for 10 to 14 days. So within this time period, if patient gets another infarction, that's the time we can't rely on troponin. We will rely on CKMB. That is the only time we will order CKMB nowadays. Every other case, we will do troponin. Ritik, very good question. If multiple troponin and serial ECG comes normal, will we discharge the patient or still look more? So depends. If patient chest pain is no longer there, most of the patient, their chest pain will be better. So if chest pain is gone and serial ECG troponin normal, then we don't need to look further. What we can, one, that we can involve the cardiology team in the hospital and they can see the patient outpatient for further investigation, or we can send the patient to their GP and GP can organize some more assessment on the heart. So GP can organize the echocardiogram on the heart. GP can also do further functional test like a stress test on the heart to see if the patient is doing anything exertional, are we seeing any angina or ischemic heart disease like ECG picture? So the GP can organize a stress test in that patient and go from there. Okay. So apart from ECG and cardiac enzymes, for patient with chest pain, if especially we are thinking of respiratory causes, then chest X-ray is important. Also, for aortic dissection, we do chest X-ray. But mostly when we are thinking of respiratory causes, then chest X-ray is really important. Okay, so that's usually the investigations, the initial investigations that we do in a patient with chest pain. There are lots of other investigations. We will come one by one. Now, every patient who has ischemic heart disease, there are always some risk factor in them. It just don't happen randomly. So the most important risk factor is the high cholesterol. And among the high cholesterol, the LDL cholesterol is the single most important subgroup that carries the risk of ischemic heart disease. So and questions in AMC, there are sometimes this kind of question, that single line question, and they say that you've got a patient with known ischemic heart disease. He has got this. What's the single most important risk factor in this patient? That is the time you will think of LDL cholesterol or high cholesterol. Okay. Now we know that HDL cholesterol are good cholesterol and LDL is the bad one. And among the bad one, we also have triglyceride. That's also bad cholesterol. But among all of the cholesterol, LDL is the single most important risk. Sometimes question will ask that what is the worst risk factor for ischemic heart disease or coronary artery disease? The worst risk factor is diabetes, because it's if a patient with diabetes gets myocardial infarction, that patient is always a high risk, because the chances of having infection, chances of having delayed wound healing is very high in this group of patient. And most importantly, sometimes they don't even feel the pain. So they get a silent MI. That's why it is quite risky for diabetic patient to have ischemic heart disease. If question asks what is the most common risk, that is hypertension. So it depends what question asks you. If they ask what is the single most important risk factor, that's LDL cholesterol. What's the worst risk factor? Diabetes. And what's the most common? Hypertension. Okay, so question is similar like this. Which of the following is the most dangerous to a patient in terms of risk of coronary artery disease? Now, if there was diabetes in here, I would choose that. But you see the options are elevated triglyceride, elevated total cholesterol, decreased HDL, and increased LDL. So increased LDL is always the worst risk factor out of these five. Okay. Correcting which of the following risk factor for coronary artery disease will result in most immediate benefit for the patient? That's another question, that if a patient stops smoking, that is the most, or that will give the greatest immediate improvement in the outcome of coronary artery disease. Now there is no way that I can help you to remember this. You just have to memorize these lines. And unfortunately, AMC likes this kind of question, so everyone will get this kind of questions in the exam. So you just need to remember it. Okay. Now, coming into our most important topic, which is myocardial ischemia. No, apolipoprotein B is not routinely tested in Australia. We only test it if we want to know if a patient has genetic risk for having a cardiac issue. Okay, so someone coming to us saying that, like, I want to know if I have a genetic tendency to have cardiac problem or cardiovascular issues. That's the time we can order it. Or if there is a significant family history of premature cardiovascular disease, like first degree relative getting diagnosed before 50, then yes, then we will do it, but not routinely. Okay, myocardial ischemia. Myocardial ischemia, we already know how the pain feels like. So the pain will be left-sided, constricting, heavy, pressured. The pain will go towards the neck. It can go to the jaw. It can feel at the epigastric region, and it can radiate to the arm. Which arm it gets radiated, guys? Both. It can get radiated to left and right. So this is where you guys get into wrong kind of information. So cardiac or ischemic heart disease or AMI, the pain can be felt in both left and right arm. So the best predictor of acute myocardial infarction is pain in both arms. So do not just rule out MI because pain is on the right arm. Very wrong. Okay. So pain can be felt in both arms. Also, sometimes it can be felt in the back, not very common, but mostly jaw, neck, inside of the both arms, epigastric region, and intrascapular region. The best predictor for ruling out acute MI is pleuritic chest pain, sharp pain, and pain that is reproduced by palpation. That is important. So sometimes if in the question you see it's a pleuritic chest pain, it's a sharp pain, and the pain can be felt when you press on the chest. You can just you can rule out myocardial infarction, right? So very important to know this kind of information because it just helps a lot in the exam. Yes, it can be felt only in the left arm, and it's more common to be felt in the left arm, but don't just rule out acute MI if the patient complaining that they're feeling the pain in the right arm. So we know the quality of the pain is described as pressure, heaviness, tightness. The radiation of pain will assist in differentiating ischemic pain from that is caused by pericarditis. So how we say that we know that ischemic pain radiation, right? And patient who has got pericarditis, though the pericarditis pain does not radiate to the left arm, neck, or jaw. And in patient with myocardial ischemia, they also have associated shortness of breath, dizziness, nausea, vomiting, and excessive sweating. So those are the associated symptoms for myocardial ischemia. If a patient has retroesternal pain, so central chest pain, but it is not exacerbated by exertion, or it is not worse with exertion, but it's worse when patient is bending forward, lifting, straining, or lying down. Consider esophageal reflux. It's very important to make sure to know that if it is a retroesternal chest pain, but the pain is not worse with exertion, myocardial ischemia or angina pain will always get worse with exertion. Patient is sitting down, not doing any exertional work, but having a retroesternal chest pain. And when they bend forward or lie down, the pain gets worse. That's the time we think of esophageal reflux or esophageal spasm. Now, coming to angina. As I said, we divide the ischemic heart disease into stable angina, unstable angina, myocardial infarction. So it is the type of the pain is same, but it is the duration of the pain. So a stable angina, pain will be same, but the pain will last for only few minutes, average 3 to 5 minutes, and it will be relieved by rest, or sometimes glycerol trinitrate. So that's a stable angina. A stable angina will get better within 3 to 5 minutes. Okay. But if it is myocardial infarction or unstable angina, it will not get better. The pain will last for more than 15 to 20 minutes. So unstable angina also includes rest angina. So patient sitting but is still having the pain. Effort angina or post-infarct angina. Doesn't really matter. There are different names, but the pain of unstable angina will last for more than 15 to 20 minutes. In the same way, myocardial infarction pain will also last more than 15 to 20 minutes. So what happens, like how we know that is it unstable angina, is it myocardial infarction? So by the look of the symptom of the patient, you don't know. You need to rely on investigations to find that out. Okay, so symptoms will be pretty much same, both unstable and myocardial. Okay, so we know already about all of this, the characteristic of ischemic chest pain. So I don't need to go into there. So this is a very good discussion. So in an ischemic heart disease patient, if you see here, so we have done a cross section of the blood vessel or coronary artery. This is the lumen of the coronary artery. And you can see that this patient has got a bit of a atherosclerotic plaque. So these patients still have a lot of lumen or space there. This patient will not have any symptoms. They are clinically asymptomatic. But when the plaque progresses and it starts to become more and more blocked, that is the time patient, especially when they do something exertional, they will start to get the pain. So when they're not doing anything, still there is a bit of a blood flow that should work. That will make sure patient getting enough blood supply. But when they do something exertional, their body needs more oxygen. But this blocked artery cannot provide that more oxygen that they need during exertion. So that is the time they start getting the symptoms. So stable angina, patient still have got a little bit of flow left. It's not fully blocked. But when a patient develops acute coronary syndrome, which include unstable angina, non-ST elevated MI or ST elevated MI, it gets fully blocked. So this atherosclerotic plaque sometimes will rupture and then it can fully block this. And when it is fully blocked, that part of the heart doesn't get enough blood supply. It's something like that. So if this is your heart, and we know that this is the right coronary artery, and we have got the left coronary artery, so left circumflex and left anterior descending, right? So let's say that left anterior descending, this area has got fully blocked. So what will happen? This part or left anterior descending artery supplies this part of the heart, let's say. So if this is fully blocked, this part of the heart will not get any blood supply and it will become irreversibly damaged and then followed by necrosis, and this can become fully dysfunctional and it can become life-threatening. So that's the pathophysiology of ischemic heart disease. Okay. Now, we have got a patient with acute coronary syndrome, which means we're not talking about a stable angina. We're talking about ACS, which includes all these three. In a patient with ACS, first thing is definitely ECG. In the ECG, we will be able to know whether it is a ST elevation or it is a non-ST elevation. If there is ST elevation, that is enough to make a diagnosis of myocardial infarction. Do we need to rely on cardiac troponin to diagnose ST elevated MI, guys? No, we don't. So if we get positive ST elevation in a patient with chest pain, that is more than enough to diagnose ST elevated MI. But yes, definitely in real life, we will order a troponin, but it's not needed to make the diagnosis. Okay. Now, let's say there is no ST elevation. Patient still have got the pain. What will you do next? That is the time we do the cardiac marker, which means the troponin. Now, this is how we differentiate unstable angina versus non-ST elevated MI. Non-ST elevated MI is still MI. So if cardiac marker is negative, troponin negative, it will become unstable angina patient. If troponin positive, it is non-ST elevated MI. So what is the difference between an unstable angina with non-ST elevated MI? First thing, the troponin will be normal in unstable and it will be elevated because in unstable angina, myocardial necrosis hasn't occurred yet. But in non-ST elevated MI, the duration of ischemia is enough, or the extent of ischemia is enough to cause myocardial necrosis. So that's why troponin will be elevated. Chest pain will be typical. Duration, same. There will be no necrosis in unstable angina, but there will be necrosis in non-ST elevated MI. Okay, basically, symptomatically, you can't differentiate between these two. You have to rely on troponin to decide. This is from John Murtagh. So we know what is stable angina. We know unstable angina. There are few other things called nocturnal angina, decubitus angina, and also Pringe metal angina. You can give it a read about this. These are not that important. We will discuss the Pringe metal or variant angina at the end. Talking about investigation for a stable angina. So now we are moving into more detail about this pain. So in a stable angina, definitely if the patient comes within the time of chest pain, we will do ECG, or even let's say patient complained. So patient came to the GP setting saying that yesterday patient was doing gardening, and 15 minutes later, while patient was gardening, patient was having this left-sided chest pain. He was very worried and he felt a bit nauseous. Then he stopped working and he took some rest and the pain went away. Pain lasted for 5 minutes. So what will you do now? Are you just going to say that your pain is gone, so bye-bye, you can go? No. There is a patient who is strongly suggestive of angina. Even though right now he doesn't have a chest pain, you have got a patient with angina and he needs further investigation. Okay? The further investigation is first get a baseline ECG. How is his ECG looks like right now? Has he got any evidence of ischemia or is it entirely normal? So we will do the baseline ECG to see how it looks like. After that, let's say in a stable angina, the baseline ECG will be normal. You will not get any findings. Will we stop there? No. We want to now find out if we can induce the pain or if we can induce the ECG changes if patient does some exertional work. So how to do that? So we have the stress test for that. So there are a lot of stress tests available. We have got exercise ECG, or we also call it exercise stress test. In exercise ECG, patient will run on a treadmill and then we will see if the patient is getting the chest pain back or if there is any ECG changes when the patient is running on a treadmill. But to do the exercise stress test, patient needs to be fit and healthy. A 70-year-old patient who has got multiple joint arthritis, you can't ask that person to run on a treadmill. So we have to also think about the patient. Not everyone can have a stress test. Okay? We will talk about what to do in that case. So we have another option of exercise thallium scan, which is a kind of nuclear scan. And In case of exercise thallium scan, you put a dye in the patient's vein. So in the arm vein, you will insert a dye, and the dye will go through the vein into the heart, and then it will go into the coronary artery and then go to the heart muscle, right? That's how it usually happens. Now, if a patient has got a blockage, let's say patient has got a blockage over here, not fully blocked, little bit blocked, let's say 60-70% blocked. And when we are doing the thallium scan, either patient will run on a treadmill, or we will give a chemical which will induce the body in a way that as if patient is running on a treadmill. I'll talk about it, don't worry. So in the thallium scan, the dye will go into the coronary artery and go into the heart muscle. Now let's say, ideally, there should be a homogeneous uptake of dye in the whole myocardium or cardiac muscle. But let's say this part of the heart did not take that much of thallium or that much of dye. What is the reason then? The likely reason is that the blood or the artery which is supposed to supply this part of the heart is blocked. That's why this part is not getting enough dye. So this gives us an idea that maybe there is a blockage, and the blockage is significant enough that when patient is doing exertion, this part of the heart is not getting any blood supply. Does it make sense? Okay. So now we come into the main point. So we're talking about stable angina investigation. We haven't gone into anything about MI yet. So we are still in the stable angina investigation. First of all, to do a exercise stress test, we need two things. You can read the patient ECG, means that ECG is normal. So when you did the baseline ECG was normal, and your patient can exercise. If these two is there, then you can send the patient for a stress test. Okay. Now, what if there is some baseline ECG abnormality? And the baseline ECG abnormality include left bundle branch block, left ventricular hypertrophy, patient is using pacemaker. So any kind of baseline ECG abnormality, you can't do the stress test because your stress test depends on the ECG changes. But this patient already got some changes in the ECG. So there is no point of doing that. So if the patient has some baseline ECG abnormality, in that case, the best two method to detect ischemia is that thallium scan, which is the nuclear scan, or we can do an echocardiogram to see if there is any regional wall motion abnormality. That means regional wall motion abnormality is when we do the echocardiogram, we also see that if all the chambers of the heart is moving equally. If we see that this part is not moving equally like others, that's what we call regional wall motion abnormality. That also suggests that maybe this part of the heart is lacking blood supply. So we will be looking into these two tests if we find that patient has some baseline ECG abnormality. Okay, you already know what we are looking for in the thallium scan, and you now also know what we are looking for in the echocardiogram. So far we found if a patient's ECG is normal and patient is able to exercise, we will go for simple exercise tolerance test or exercise stress test. But patient has abnormal ECG, but patient can exercise. In that case, we go for either a thallium scan or we do the echocardiogram, which is what we call a stress echo. Okay. Up to this, are you guys okay? Are you clear? How will I know if ECG is not normal? Because you should be able to read ECG. When you do the baseline ECG, before sending this patient to any test, you will do a baseline ECG. That's how you will know if it is normal or not. Yeah, so this is different from chemical stress test. So in this kind of test, so these two tests, patient will be running on a treadmill and we will do these two tests while the patient is running. Okay. So yes, you will inject the dye and patient will then run on a treadmill. Now let's say it is different. The ECG is normal. That means there is no ECG abnormality, but patient can't exercise. So if patient can't exercise, you can't ask the patient to run on a treadmill. So you have to give a chemical which can increase the myocardial oxygen consumption. So that is called chemical stress test. So you give a chemical which is usually dipyridamole or adenosine or dobutamine. This chemical can increase the myocardial oxygen consumption. It will be exactly the same as if patient is running on a treadmill. So we will give dipyridamole or adenosine, and then we will give the thallium. So that's the thallium scan. And for echocardiogram, we will give dobutamine. Okay. So if patient cannot exercise, then you give the chemical and do the same thing. Either you do the thallium scan or you do the echocardiogram. It's very easy if you understand what I'm talking about. That's where it is wrong. So we are talking about stable angina. Stable angina patient, as a baseline, they don't have chest pain, Dr. Saida. Okay. So if a patient has chest pain and also you see changes in the ECG, it's not a stable angina anymore. Because a stable angina usually get better within 3 to 5 minutes after taking a rest. The reason why we are doing the ETT is to find out that actually what happens when they are doing the exercise. Because when you are doing the ECG on a stable angina patient, their pain is already gone. So you can't actually find out anything. So you want to stress the patient out and then find out what happens. It's not like a huge stress that you will induce a heart attack. Okay. So as soon as we see that there is some changes happening in the ECG, we will get the patient back to rest and it will come better. And these are usually done by cardiologists, so they are well equipped to treat this kind of patient if something happens. Usually, I have never seen someone got a heart attack while doing a stress test. Okay, so are you guys clear on this test? Any questions, anything that you want me to repeat? So after giving thallium, so thallium is the nuclear scan. So we use it's called like a gamma camera. With the gamma camera, we can check the blood flow. And for the echo, like definitely after giving, we can use after giving the dobutamine, then we do the echo to check for the regional wall motion abnormality. So for thallium, you use the gamma camera, and for the dobutamine, we are using the echocardiogram. Okay, so let's summarize everything. So we are talking about a stable angina patient. For a stable angina patient, first thing we will do is a ECG, baseline ECG. Okay, let's say definitely baseline ECG will be normal, but we want to see if there is any other finding. So if there is a left ventricular hypertrophy finding, if there is left bundle branch block, that means it's not entirely normal. We also need to check whether the patient is able to exercise. These two will detect what kind of stress test patient will need. Let's say patient ECG is normal, patient is able to exercise, then it's simple. We send the patient for exercise tolerance test. But let's say the ECG is having some baseline abnormality, but patient can exercise. In that case, we are doing the stress thallium or stress echocardiogram. Let's say ECG is normal, but patient is unable to do exercise. So we can't ask the patient to run on a treadmill anymore. Then we do the chemical stress test. So you do either chemical thallium or echo. All right, nice and easy, everyone. Now, why we're doing this test? There is a reason. We're not doing this test for nothing. Have a look on this patient. A man with atypical chest pain is found to have normal nuclear isotope uptake in the myocardium at rest. So at rest, patient's nuclear uptake is normal, but on exercise, there is reduced uptake in the inferior wall. 2 hours after exercise, so after taking rest, the uptake again returns to normal. What does it mean? It means that when patient is exercising or doing anything exertional, there is reduced uptake in the inferior wall of the heart. That is what we call inducible ischemia. That means when the patient is doing something, then the heart is not getting enough blood supply. This is a patient who has significant blockage, because without significant blockage, they should not get this kind of finding. So what are we going to do next? We want to find out how much blockage is there. So if we want to know how much blockage is there, that is the time we do the coronary angiogram. What coronary angiogram is going to do? In coronary angiogram, we'll give the break just in few minutes because we're in the middle of something. Let's finish this. So in coronary angiogram, we're going to put a dye. So this is a CT coronary angiogram. Remember, there is two kind of coronary angiogram. One is invasive coronary angiogram, where you put the catheter in, and then there is a CT coronary angiogram. In the CT coronary angiogram, again, you put a dye, and the dye goes through the coronary artery, and it can say how much blockage is there in each artery. Okay, what it will do? So let's say we did angiogram. In the angiogram, if there is more than 70% blockage, that is clinically significant. If a patient has got more than 70% blockage in one or two vessel, then we put a stent. maximum 2 stent at a time. But let's say a patient has more than 70% blockage in 3 vessel, or if the left main coronary artery is blocked, or 2 vessel in a diabetic patient. So just remember 2 vessel in diabetic or 3 vessel that will need a CABG. So that is the patient who need a coronary bypass. So the reason why we need to know all of this is because the last thing, because this is how we can find out or we can prevent a patient to have a acute myocardial infarction. Does it make sense, guys, so far? So left main is the left coronary artery divides into 2 branches. Okay. Before it divides into 2 branches, that's what we call left main coronary artery. So in a stable angina patient, we can still do angiogram to be sure. Now there is a gray area in this case. If a patient has chest pain on exertion, then usually you'll be looking for, like, patient might need a stent. If a patient needs a stent right away, then we can just go for angiogram straight away. But most of the time, cardiologists, usually they will start with a CT coronary angiogram. They will find out whether this patient actually needs a stent. Okay, if they need a stent, then they will go for the, that to put a stent in, they will do a coronary angiogram in theater, which is that invasive one, and then they put a stent in. So most of the time they will have a CT coronary angiogram first, especially for a stable angina. No, thallium is different, echo is different. We do only one of them. Thallium is a nuclear scan. So you put the nuclear isotope, and then you take pictures as the isotope moves into the heart muscles and all. You take pictures, multiple pictures by gamma ray. Now we don't need to go into that detail because it's not in the scope of AMC MCQ exam. It's just going to waste your time. So just remember that with the thallium, we just know that if part of the heart muscle is not getting enough blood supply. So you either choose one of them. Either you do a nuclear thallium scan or you do an echocardiogram. You don't need to do both. No, if it is less than 70%, then it will be just prevention. So you can give some medications. We will come into that. No, usually they will not say like this. And we don't need to go into that detail. So AMC, you only will say coronary angiogram or angiography, same thing. And if the AMC says, so let's say there is a CT angiogram in the option, and then there is a percutaneous coronary intervention, which is the PCI. PCI is usually only done if a patient has got acute myocardial infarction, especially ST elevated MI, which we will come into. So that's why I say that almost every time in a patient who has a stable angina, you're not going to go directly to the PCI. You will start with a CT coronary angiogram. But AMC doesn't go that deep. They know that you are junior doctors and you don't need to go into that deep because you're never going to do a angiogram as a junior doctor. So they know that. Yes, so to see the block, we do the CT coronary angiogram first. There is nothing preferable. We can do either one of them, thallium or echo, doesn't matter. A stress thallium patient will run on a treadmill. Chemical thallium, you're just going to give a medication. We just discussed when angiogram is indicated, Dr. Vince. Same stress echo, patient will run on a treadmill. Dobutamine echo, patient will not run. You will just give the chemical. If thallium is normal, it means it is not a cardiac pain. It's something else. For stable angina, so what we have discussed so far, Muniat. So if the patient, so let's say you thought the patient has a stable angina, and then you have chosen a stress test. It could be any of the stress tests that we have mentioned. If the stress test come back positive, then you do an angiogram. So this is the angiogram, how it looks like. You can see that in the coronary angiogram, this part, definitely there is a block. This part, there is a block. Okay, so that's what it shows. These are all the indications of coronary angiogram, where we can see the number one is positive stress test. And there are a few others which we can do. Okay, management of stable angina. Yes, we still do an echo after thallium just to see the function of the heart and everything else. Yeah, so patient will usually have a echo with it, but it is not termed as a stress echo. It is termed as thallium, or we call in Australia, we call it myocardial perfusion scan. Okay, that's the thallium scan. There is no difference between coronary angiogram and CT angiogram. It's the same thing. The full name is CT coronary angiogram. You are asking what is the difference between CT coronary angiogram and percutaneous coronary intervention. That's the difference you're asking. CT coronary angiogram, you just put a dye and you find out which artery is blocked. It's not invasive. It's just a CT scan. This one, the percutaneous coronary intervention, is an invasive test where you put a catheter through the femoral, through the groin, and then it goes into the heart, and then also you put a dye there, but that's invasive because you're putting a catheter there. That's called percutaneous coronary intervention. This is usually done in a ST elevated MI because you want to put a stent through that catheter. Make sense? Okay. Before we take a break, I want to finish the stable angina because after the break, we're going to discuss the MI. MI is much more important. So stable angina management, along with everything else, the lifestyle management is most important. So no smoking, weight reduction, exercise. There is nothing more important than doing this secondary prevention. So controlling the blood pressure, controlling the diabetes, controlling the blood cholesterol, these are always the most important thing. What if, now this is the medical management for angina. So not every angina will require a stent. A stent only needed when there is more than 70% block, as you have seen. In the other group of patients, the medical treatment will be when they get the angina pain, they can use a nitrate. So the glycerol trinitrate spray under the tongue, or we can give tablet as well. Okay, they also need to use aspirin. So the main treatment during acute angina pain is the nitroglycerin spray. Now, to prevent angina pain, what else we can add? So in every angina patient, usually, especially if the pain is really bad, We will always add a aspirin to prevent any further clot formation. We will give them a beta blocker, which is cardioprotective beta blocker or cardioselective beta blocker like atenolol, metoprolol, not propranolol, and plus a nitrate. So these are the medication that we will give to angina patients. So main is glycerol trinitrate, which is a spray under the tongue they will use when they get the pain. It's not a regular medication. Unless patient gets the pain regularly. If the patient gets regular chest pain, then we can give them the isosorbide mononitrate, which is kind of a nitrate. Okay. So for moderate angina, the patient will be on a aspirin, they will be on a beta blocker, they will be on a nitrate. That's the treatment. If it is persistent angina, not prevented by beta blocker, then you can add a calcium channel blocker such as nifedipine or amlodipine. Okay, so ideally what you really need to know from here, that what to give to a patient with angina when they have the pain. You give the nitrate. And as part of regular medication, what we will give? As part of regular medication, initially we start with aspirin, beta blocker, and nitrate together. Still patient getting pain, then you just add a calcium channel blocker. Okay. Now we don't give both calcium channel and beta blocker at the same time because it can cause more problem. So you give either one of them. So we talked about coronary angiogram. We know about when to give a stent, when to go for CABG. All right, that's all about stable angina. Let's take a 5-minute break. And after the 5-minute break, we're going to start with a very, very important topic, which is myocardial infarction. Okay, and that is the most important topic for chest pain. There's a lot to learn. So we'll come after 5 minutes and we'll go from there. Thanks all. All right, everyone, let's be back. Okay. So, myocardial infarction. Myocardial infarction will be our first priority before we discuss anything else because this is important. And if we still get some time, we'll get into others. Okay. So, Dr. Ahsan, you find that loophole, right? So, if a stable angina patient had baseline ECG abnormal and patient is unable to perform exercise, you can't do any stress test in that patient. You just need to take the patient for a CT coronary angiogram. There is nothing else we can do. Okay, moving on to myocardial infarction, which is really, really important. A lot of things come from here. So try your best to understand each and everything from here. Okay, so starting with the ECG changes of ST elevated MI, because it is entirely dependent on the ST elevation on the ECG, right? So in myocardial infarction, we know the pain is going to be the same. So, and then you do the ECG, and ECG will have some changes. Immediately, you get hyperacute tall T wave. So the T wave, you can see that this is P, that's QRS, and that's the T wave. That's normal, but it's not normal to have this. So hyperacute tall T wave is the first thing that we see in the ECG. And then after that, we start to get the ST elevation. Now, ST elevation we will show you in the ECG class. That is not part of the free 2-week session, but once as part of the enrolled course student, you will get an ECG class after this 2-week session, and we will show you what the ST elevation looks like on an ECG. We also get Q wave and T wave inversion in this patient. Okay, these are the changes that we see in ST elevated MI. So the question that comes frequently, you have got a patient with a chest pain and the ECG is showing ST elevation. What is your next step? The next step for any patient with a ST elevated MI is to give the patient aspirin immediately. So 300 milligram aspirin orally, unless it is contraindicated, patient should have that straight away. We call it monotherapy. The monotherapy include aspirin, nitrate, oxygen, and morphine. This 4 is the initial treatment for acute ST elevated MI or any kind of MI. So the aspirin is the first thing, and it can save the patient's life. And this is the most important one. Others are not super important because this doesn't have survival benefit. But aspirin has a survival benefit if you start the patient immediately, because every second the patient is waiting, some part of his heart muscle is dying, and aspirin can prevent that. Okay, so that's really important to start. For the ongoing chest pain, and if the patient is hemodynamically stable, so we have taken this from therapeutic guideline, which is really important. So for ongoing chest pain, we will give the patient nitrate. So glycerol trinitrate spray or the tablet. Can we give nitrate in a patient who is hypotensive? If the patient's blood pressure is less than 90/60, that means patient is hypotensive, you can't give them nitrate because it will drop the blood pressure more. So that's why they said hemodynamically stable patient. Even after giving the nitrate, still there is persistent chest pain. Then you add fentanyl, which is an opioid, or morphine. Do we need to give oxygen to every patient who has acute MI? No. Give oxygen only if patient is hypoxic and if the oxygen saturation is less than 92%. So that is the idea. That's what you need to remember. For angina, we only start aspirin, not dual antiplatelet. We'll come into that. Let's wait. There are a lot of things there, so don't come into the conclusion yet. This is the initial part. So in the MONA, we give aspirin, we give nitrate, that's for ongoing chest pain. And if still there is pain, then morphine or fentanyl. And oxygen depends on the saturation. Out of these four, which one is the most important? Aspirin. Please remember that, because I keep saying that because a lot of questions come from here. Now, have a look at it. We've got a patient. So this is all from therapeutic guideline, which is the flow chart that you see here. Very important for exam. Let's say we have got a ST elevated MI patient. What we have done, we have given aspirin first. When we give aspirin, we plan the perfusion therapy in this patient. So reperfusion, so a lot of time questions come like that. So they give you a scenario of ST elevated MI patient, and they say that you have given aspirin. What will you do next? Now you choose all of this: morphine, oxygen, nitrate, but that's not what this flow chart shows. I know that this is important, but these are not going to save the patient. So if they give you a scenario where you have given the aspirin in a ST elevated MI patient and they're asking for the next step, that will be reperfusion therapy, which is the percutaneous coronary intervention. If there is a lot of ifs and outs in here, we'll discuss that. But just remember, after aspirin, if exam question says what will be the next, that's always going to be reperfusion therapy. Now we have two kind of reperfusion therapy. One is this percutaneous coronary intervention, which is that invasive angiogram we talked about. And then we have fibrinolysis. Okay. PCI, if it is available, this is going to be always the choice. If PCI is not available, then only we choose the fibrinolytics. So can we just give PCI to every patient, even if they come 2 days after a MI? No. There is a thing in here. Reperfusion is recommended if the patient presents within 12 hours of onset of chest pain. Remember this one. So if patient comes within 12 hours of onset of chest pain, then only we can choose any of these. Depends on the availability. Now, what if they come after 12 hours? If more than 12 hours, reperfusion still can be considered if there are signs of ongoing ischemia. That means in the ECG, you see dynamic changes, still changes happening on the ECG. Or you see that patient is still having a lot of chest pain, patient is going into hypotensive, like cardiogenic shock. So if there is a lot of complications happening even after 12 hours, then you can still consider reperfusion. Now, we have got a patient who came within 12 hours and PCI. Then we need to ask, is PCI available within 120 minutes of first medical contact? This is in some guideline, it says 90 minutes. Therapeutic guidelines say 120 minutes. So remember 90 to 120 minutes. So within 2 hours of first medical contact, it's not when the patient started having the pain. So first medical contact, within 2 hours, are you able to provide PCI for this patient? That's the question we ask. If you can, then you arrange the PCI for this patient. Okay. Along with the PCI, then we also add the dual antiplatelet. So you're going to add either clopidogrel or ticagrelor or prasugrel, any of the dual antiplatelet we can add. And also we will give parenteral anticoagulation, which is the heparin. So this will be together, like all of them will be there side by side. So this is the first thing we need to see. Is the patient came within 12 hours of chest pain? Yes. Is this hospital has PCI available? Yes. Can you arrange a PCI within 120 minutes? Yes. Then arrange PCI and you start giving the patient dual antiplatelet and the parenteral anticoagulation, which is heparin. What if PCI is not available within 120 minutes? Let's say it's a rural hospital and the tertiary hospital is 3 hours away. Definitely, you can't wait for 3 hours. In that case, we go for the thrombolytic therapy, which is the same fibrinolytic therapy. Before giving thrombolytics, we want to see if the patient has any contraindication to this. There are contraindications to fibrinolytic therapy. If patient doesn't have contraindication, then we proceed with the thrombolytic drug, and we also give the same dual antiplatelet and heparin. Then, was the thrombolytic therapy successful? Yes. If it is successful, still we are going to transfer the patient in the tertiary center within 24 hours, because that patient just had a thrombolytic, but still that patient will need an angiogram and if needed a stent. Okay. So the question that comes in exam is from this flow chart. So you need to first think step by step. Is this is a patient with ST elevated MI? Yes. Give aspirin. I have given aspirin. What's next? Plan reperfusion. How to plan? Did this patient came within 12 hours? Yes. So then we know that PCI is best. Can we give PCI within 2 hours? If yes, then we arrange PCI. If no, we go for thrombolytics. Clear? Everyone? Yes, we can give clopidogrel and aspirin as a dual. We will know the time. So if we don't know the time, then we actually see for ongoing ischemia and all other complication. It's very unlikely we will not know the time. There is no need to remember the dose of any medication. Dose doesn't come in exam. In hypotensive patient, we just skip the nitroglycerin. No. So after 2 hours, because we should not wait for more than 2 hours for arranging a PCI. Because if you wait more than 2 hours, it means that it's just going to waste time. Now remember, Toma, it's not 2 hours after the chest pain. It is the 2 hours of first medical contact. That's where you get confused. So don't make these two things same. First thing is, did this patient came within 12 hours of chest pain? If yes, then yes, PCI is a very good option. Now, yes, I want to give PCI, but is it available within 2 hours of first medical contact? That means patient came into your hospital. Are you able to give the PCI within 2 hours of entering into the hospital? If you can, then you give it. If you can't, you are just wasting time and patient is just having loss of cardiac muscle every time you are waiting. So that's why you will not wait for more than 2 hours. You will just go for thrombolytics in that case. Yeah, so that's what I say. JM says 90 minutes, ETG says 120 minutes. We will keep the ETG as our guideline because this is more like usually commonly used in Australia. Yes, we give aspirin clopidogrel immediately after making STEMI diagnosis. So usually all of these will be given all together. Side by side. It happens side by side, but when exam questions come, you follow the step that is in this flow chart. Okay. So give all patient present with ST elevated MI immediate dual antiplatelet therapy with aspirin and a P2Y12 inhibitor. So could be any of those, prasugrel, ticagrelor, or clopidogrel. Okay, so usually you will give both dual antiplatelet in this patient. So any of them will be fine. You don't need to know the dose, just remember the name. Okay. 70-year-old man comes to the ED with crushing substernal chest pain for an hour. ECG shows ST elevation. What is the most appropriate next step in this patient? Simple. Aspirin. There is no doubt, right? Okay. What's this one? Same patient, but you have given aspirin. What will be the next step? We have got everything: CK, oxygen, morphine, thrombolytics, angioplasty, troponin. After aspirin, anything which has PCI, angioplasty, same thing. So you're going to go for angioplasty in the answer. Now you can tell me that yes, this patient needs everything else. But as I said, according to the flow chart, after aspirin, the PCI or angioplasty will be your answer in the exam, because these two can save the patient's life. So you can see that angioplasty is associated with the greatest mortality benefit of all the steps listed in this question. All of the answers are partially correct because we do this for the patient. We give morphine, oxygen, nitrate, but they don't lower the mortality. Okay, so that's why we're choosing the angioplasty in that case. Okay, now we're talking about the reperfusion therapy. If PCI available, that is the best available treatment. But it is best if we can give it within 12 hours of onset of symptom. Thrombolytics such as streptokinase, or we have tissue type plasminogen activator like altiplase, retiplase, any of those we can give. But that's if PCI is not available. What are the contraindications for thrombolytics? You should remember the absolute contraindications. So if someone has active bleeding disorder, closed head injury within the last 3 months, suspected aortic dissection, previous intracranial hemorrhage or ischemic stroke within the last 3 months. This group, definitely you can't go for thrombolytics. What if you can't provide PCI within 2 hours, but patient has this? That means they have a contraindication to thrombolytic. So you can't give PCI within 2 hours, and there is contraindication to thrombolytics. Nothing to do actually. You just need to transfer the patient to tertiary hospital for a PCI. Late presentation. After 12 hours, reperfusion with PCI or fibrinolysis is not routinely recommended, especially patient is asymptomatic and hemodynamically stable. So reperfusion immediately, like urgent reperfusion, is no longer needed if patient comes after 12 hours and they are asymptomatic and stable. But eventually they will need a coronary angiogram and either a stent or bypass depending on the angiogram report. Okay. Now, let's say we have done the treatment. We have done PCI, we put a stent in. What are the further management for MI? So patient with ST elevated MI will be on a dual antiplatelet therapy, aspirin and clopidogrel, for at least 6 to 12 months. Previously, we used to do 12 months. Nowadays, the stent, usually we can just go for 6 months of anticoagulants, which is clopidogrel. So clopidogrel will be stopped after 6 months. Then we add beta blocker in this patient because it stops the cardiac remodeling after the MI. And if the patient has high cholesterol, we will give them a statin to lower it down. These patients also will be started with ACE inhibitor, especially with signs of left ventricular dysfunction or if they have high blood pressure. So the main treatment after ST elevated AMI will be dual antiplatelet, beta blocker, ACE inhibitor, which is a blood pressure medication, and a statin. This 4 is for everyone. So far you learned about the ST elevated MI management. What about non-ST elevated MI? Yeah, bisoprolol is okay. There is no problem if we use dual antiplatelet before PCI. Why 12 hours later is not urgent anymore? Because the myocardial injury has already happened for that patient. So if you give it urgently, it's not going to do a lot of change. Sometimes if you can give the PCI within 12 hours, you can still save a lot of cardiac muscle. But after 12 hours, it's done. So there is no point of actually do it urgently anymore. It's not going to save that muscle. That muscle is already dead. And yes, reperfusion injury can also happen. Yes, that's right. Only one, definitely, Snigdha. Every patient with ST elevated AMI, they will have dual antiplatelet, aspirin, clopidogrel, must. Not, they will not get only aspirin. Now, non-ST elevated acute coronary syndrome. So same, this is also a AMI. Patient will get aspirin, and after the aspirin, we will determine the need timing of invasive coronary angiogram. That means in a non-ST elevated AMI, the treatment is same. But for a non-ST elevated AMI, we decide who needs the coronary angiogram. Let's say very high risk group, patient who is unstable, patient who is in cardiogenic shock, refractory chest pain, life-threatening arrhythmia. So any of this is there, that patient, even with non-ST elevated acute coronary syndrome, they will need an invasive coronary angiogram. And they will also have they will have dual antiplatelet, aspirin, clopidogrel, and also heparin. Okay. Now, so this patient who has very high risk, they will need an invasive coronary angiogram within 2 hours of diagnosis. But for this high risk group, they only need the invasive angiogram within 24 hours. So it's not urgent anymore for them. So you can do it within 24 hours. So that's for established non-ST elevated with elevated troponin level who are hemodynamically stable. Okay. Now, this is not important for exam. It doesn't come. All you need to know for non-ST elevated MI that for non-ST elevated MI, there is no role of reperfusion therapy, which means there is no role of immediate PCI, percutaneous coronary intervention, unless patient is really sick, or there is no role of fibrinolytics in this patient. So the treatment solely depends on, we go for aspirin, we give dual antiplatelets, so aspirin plus any of these prasugrel, ticagrelor, or clopidogrel, and we give low molecular weight heparin, and then we organize the angiogram. If angiogram shows that patient has significant blockage, then yes, we might need to do angioplasty or a stent, but it depends on the angiogram report. Okay, so basically for this group of patient who has non-ST elevated AMI, urgent reperfusion is not a must thing to do. We can wait. Okay, unlike ST elevated AMI, where you need to do the PCI within 120 minutes. That means within 2 hours, that patient will need a PCI. Okay, but for most of the non-ST elevated MI patient, you don't need anything urgent within 24 hours. You can stabilize the patient with medical treatment, aspirin plus clopidogrel plus low molecular weight heparin, followed by you do an angiogram later on. Yes, heparin is also given initially for ST elevated. So for ST elevated, also heparin will be given. Okay, let's have a look. We have got a patient who comes to the ED with chest pain for the last hour that is crushing in quality, does not change with respiration or position. ECG came as ST segment depression and aspirin has been given. What is the most appropriate next step in the management of this patient? Ideally, we would now within 1 hour, if we do troponin, it will not be high. But this patient has got chest pain for 1 hour, crushing in quality, ST depression. So likely chance is that it's either an unstable angina or it's a case of non-ST elevated MI. But still, we need a troponin to be sure. But there is no option of troponin in here. So you have an option of giving heparin, thrombolytics, this glycoprotein inhibitor, nitroglycerin, morphine, angioplasty, metoprolol. What will you do? As I said, for an unstable angina or non-ST elevated MI, angioplasty is not an urgent thing to do. We don't give thrombolytics as well for this patient. So the best one out of all of them, which can save the patient after aspirin, is heparin. So if you look over here, heparin will prevent further clot formation. It will not dissolve the clot that is already formed. When patient has acute coronary syndrome, but there is no ST segment elevation, there is no benefit of thrombolytic therapy. Nitroglycerin, morphine, oxygen, they don't clearly reduce the mortality associated with it. Okay, so when we get a questions in terms of acute coronary syndrome in the exam, you think of mortality benefit. So after aspirin, in ST elevated MI, mortality benefit is the reperfusion therapy, PCI or thrombolytics. For non-ST elevated MI, after aspirin, the mortality benefit is from heparin. Clear? So please remember that it will become very nice and easy for you. So that's all about the treatment of myocardial infarction. We should also know what are the complications of ST elevated MI. Patient can get heart failure. This is not the part of today's class. Next class, we will discuss that. They can get cardiogenic shock. Sometimes they can get pericarditis. They can get a post-MI syndrome known as Dressler syndrome, where patient get a kind of a pericarditis-like pain. Okay, they get pericarditis, fever, and pericardial effusion. So treatment will be same like pericarditis. Okay, have a look on this Prince metal angina. Prince metal angina or variant angina is uncommon, but it can get confused in the exam. So in this case, patient also gets severe angina. It looks like a chest pain, like heart attack. So patient will get chest pain, but the chest pain will occur at rest, most often at night or in the early morning. So you've got a patient who is having severe chest pain happening usually at rest, and you have done a ECG in Prince metal angina during the chest pain, you will get ST segment elevation. So that will definitely make you think that this is a ST elevated MI. You will take the patient for angiogram and you will find out there is nothing wrong. So for this group of patient who has ST elevation on the ECG but angiogram is normal, that is the time you think of Prince metal angina. How to confirm? We can do a argonovin test. If we give argonovin, it will trigger coronary spasm, confirming the diagnosis. So nothing, Prince metal angina is this patient gets sudden spasm of the coronary artery causing the chest pain. But it is functional, you can say, because there is no mechanical obstruction in the coronary artery in this patient. So because it happens due to a spasm of the coronary artery, if we give something which can dilate the coronary artery, that will be the treatment. So treatment is nothing but calcium channel blocker or nitrate because both can do coronary artery dilation. Clear? No, ST depression in some leads will not be treated as ST elevated MI. For ST elevated MI, there has to be ST elevation. But there will be some reciprocal ST depression. That's a different scenario. We don't need to discuss the type of MI. That's not needed for exam. It's different. So when we say coronary angiogram, it depends on the scenario. Coronary angiogram basically means it's a CT coronary angiogram. That means we do a CT scan, put a dye, and then find out the blockage. But when it is invasive angiogram, that is actually the PCI, or when we put the stent in, or when we put the catheter in. Therapeutic guideline is the most appropriate guideline. Then I would say RSCGP, then John Mortag. Yes, you will have access to all these notes in the portal. Okay, we're now discussing some of the other chest pain, and then we should be able to finish the class. So aortic dissection. Aortic dissection is also one of the most important thing to rule out in a chest pain patient. This patient will come to us with sudden severe midline chest pain with a sensation of tearing, ripping sensation, and the pain will go to the back. If we get a patient with aortic dissection, what is our next investigation? Definitely patient has chest pain, so you will do a ECG. You can do a chest x-ray. Those things are initial test, but the test that you will do to confirm the diagnosis, so you will do a CT angiogram as the, so after doing the initial ECG chest x-ray, you do a CT angiogram. CT angiogram is quite fast, it's easy to do, and it can get the diagnosis almost every time. But so that is the problem. So if they say what is the best diagnostic test for aortic dissection, that is the TOE. So transesophageal echocardiogram is the best, most appropriate. But because it has, patient needs to be in a theater to do this, we can't just do this one without managing the theater. So it takes time. That's why if we are definitely will be in a hurry, we will do a CT angiogram most of the time. Okay, so next most appropriate test for diagnosis of aortic dissection after ECG and chest X-ray will be CT angiogram. And if the question explicitly asks that what is the best test, that will be transesophageal echo. Now, aortic dissection, we divide into two types as part of a Stanford classification. We have type A, type B. Type A includes these two. So basically, any type A you can see is the entire aorta having the dissection. And this type 2, the dissection will be any dissection proximal to the left subclavian artery. So if the dissection or tear happens in the ascending aorta part, that will be type 2. So together type 1 and type 2 is what we call type A. The management of them are quite similar. Whereas type B is any aortic dissection after the left subclavian artery. And the management of this one is a bit different. If it is type B, almost all of the aortic dissection patient has high blood pressure. For type B, maintaining the hypertension is the first treatment. So for type B patient, we will need to control the blood pressure. To control the blood pressure, our initial choice is IV beta blocker, which is IV labetalol. And if still IV labetalol is not able to reduce the blood pressure, then we try the IV nitroprusside. But if it is type A, there is not a good dissection. They will need an emergency surgery for most of the patient. Okay, Nice and easy. Just remember this. There is a lot to learn from here, but that's all that you need for AMC. Yes, in case of Prinzmetal angina, you will still need to do the CT angiogram. And Siddhartha, there is a lot of things in the DFPT range. We are not discussing that part for elective surgery and management of antiplatelet drug. That's a different thing. There's a lot to learn for that part. We will discuss that later on in the course. So if you need to learn a little bit more about aortic dissection, you can use any of this link that is given in your note. And we have got pericarditis. So if we got a pericarditis patient, we know that how the pain usually will come. Patient will have this kind of sharp left-sided pain, and the pain will be aggravated by cough, deep inspiration, sometimes even brought on by swallowing. It is worse with lying flat and relieved by leaning forward. Many times patient, like in real life, you will see this kind of patient likes to sit forward because that relieves their pain. Okay. Sometimes the pain can be a bit different. Like it can feel like a crushing retroesternal pain radiating to neck and arm, mimicking MI. So it's quite uncommon, but it can happen. And you can get pericardial rub in this patient. Almost most of the cases in acute pericarditis, you will find out that the patient had a recent viral infection. Many times there is no cause. Sometimes it could be related to if a patient has got uremia, like renal failure, that can cause pericarditis. If a patient has connective tissue disease like rheumatoid arthritis, SLE, that can also present as pericarditis. Okay, so those are the causes that you will be ruling out. If you suspect pericarditis, your first test is ECG, and then also you can do a echocardiogram. So ECG will give us global ST elevation. When we do the ECG class, I will show you how the ECG of pericarditis looks like. Treatment is very important. So the best treatment for acute pericarditis is colchicine. So you give colchicine for 3 months, plus you can add any of the anti-inflammatory, either aspirin or ibuprofen. Okay, make sense, guys? Most appropriate test for aortic dissection is transesophageal echocardiogram. If they say next most, then you can think of CT angiogram. Ethan, you will have to rely on Australian guideline. There is no other guideline that will be followed for AMC. To reduce pain in MI patient with hypotension, what to use as we can't give nitrate? You still have like opioids, morphine, fentanyl. You can use that. No, Sabrina, CT angiogram first and then TOE. All right, so that's that. Costochondritis, as I mentioned, that costochondritis, you can see the costochondral junction. The patient will have inflammation of this joint, and they will come with a unilateral sharp pain, and the pain will also be exacerbated by breathing, physical activity, or even just pushing on that specific area. That's all. That's all we do. We discuss from here. All right, guys, I hope you enjoyed the session. I know it is too much for you to handle, but this is how we have to take the class. If we can't finish chest pain in a single class, how we can finish a course? So I had to go through that with you, and I know it is definitely very, very difficult for many of you, but you persevered. Most of you are here, which is a good sign. Okay. So nothing to worry. I don't want you to remember everything. If you are course student, you are already in the portal. You can always go through the recordings and just give it a go again. It will make more sense. And any kind of portal issue for candidate like Mushfiq, please inbox me in the messenger. I can't help you here. So send me an inbox. Either me or my team will have a look into that. QBank, we will upload that after the 2 week session is over. Okay. So when it is difficult to arrange a TOE, then we rely on the CT angiogram. So for this topic that we discussed, all you need to do is to go through the note. You don't need to go through anything because I have included every possible detail that you need to know. You don't need to go through anything else. This is more than enough. If you can retain all this information, there will be nothing else that can come from chest pain. Okay. Coronary artery calcium score. Calcium scoring is kind of a preventive test nowadays. We don't do it in a patient who has symptom. So let's say a patient is moderate to high risk. So we use those cardiovascular risk chart. And in the cardiovascular risk chart, if a patient has moderate to high risk, then we can ask the patient to do a calcium score. According to the calcium score, we can decide how risk the patient has. The score has like 0 means there is no calcification, 0 to 100 means patient has small amount of calcification and that can be managed just lifestyle. But anything more than 100 means patient has medium calcification. So you will consider a statin for that patient. And if patient develops symptom, you might need to do some test, like functional test, like thallium scan. It's not very important for exam, but knowing a little bit about it doesn't hurt. So you need to learn everything that is in the PDF and what we discussed today. Books will be uploaded after 2 weeks free session. At the moment, we are very much concentrated on this two-week session. And also, you guys definitely sending a lot of messages. We are focusing to answer you. And once this is over and we are in the full rhythm, then we will start uploading all the books and everything. Okay. Yes. Alhani, when you subscribe to the course and you make the full payment, you get the last batch full recorded class. So if your exam is in April, then yes, that is definitely a good idea. So you will be getting all the last batch recordings. So notes will be uploaded by tomorrow. Okay, so usually after the class, because it's already 11 p.m. in Australia, I'll need to I'll need to sleep as well. So and also recordings will take some time. So you'll get it in the by tomorrow. Okay. Yes, it is more than enough if you just study what we discuss in this course. Takotsubo cardiomyopathy no need. And joining. So the first question solve class and PDF. So if you go into the portal and search the recent question solve section, you'll see there is a topic of tips and tricks. Under that, there should be that first question solve class. You don't need to study detailed anatomy, physiology. That's not needed. Access to the notes and portal has already been given for the enrolled student. No, Muniyat, I don't think you can use iPen to make notes in the uploaded PDFs. Rama, if you make the payment today, usually the admin team will have a look at your app, like they will need to approve you into the portal, which can take 24 to 48 hours because tomorrow is Saturday and Sunday. So usually in the weekend, our team takes some break. So most likely you will get it by Monday. You don't get immediate access after paying. So we will make sure that you are that we get a lot of scammers who wants to enter into the course. So we always check everything before you can enter into the course. No, ETG is not something that we can provide. It is completely a different group. If you want, then you will need to subscribe there. How to join the course? So to join the course, you will need to go into our website. So I can show you where to go. So if you just type firstaidamc.com.au, then it will take you to our portal. And if you just go into the 5 months MCQ course, if you want to check the information, click here. Or if you want to register, then you just click there. Then it will take you to the process. They will ask for your email address. Your email address will get a one-time password. Once you put it here, submit, and then you'll give some personal information, documents, payments, and then you will need to wait for a few days to get the access. If you can't find the previous class in the portal, it means you did not make the full payment. Only if you have made the full payment, you will be given access to the previous class. Yes, so you see, we are doing a live class at the moment. There will be live class. So all of the classes that we take are live sessions. So we give live sessions as we are doing now, and the recorded classes are for the last batch. Okay. As I said, Shalini, exam can be as hard as they want. We make sure that you are well prepared. So the notes and everything that we are doing with your course is completely detailed, and we made sure to get all the updated guidelines. So there will be nothing that they can ask you then you will not be familiar with. So we'll make sure that if exam get hard, our students usually will be in that standard that they can pass just like before. So there is nothing you need to worry about in that case. Portal is accessible for 10 months, and then so you have two options. So either you can enroll the 10 months access, or you can enroll for 15-month access. Yes, you see, so you get last batch recorded class, and also you get live class in the new batch, which is 3 days a week. Yes, QBank is from Recos. Yes, if you log out, you will be able to log in using the same browser and device. Now, if you want to have subscription to any QBank apart from the course, you can, but our course is sufficient. You can't log in multiple device. We already discussed that. Payment is in Australian dollar, not USD. So payment processing confirmation takes 2 to 3 days at least. No, Hassan, you should be able to find out the last Tuesday class. I will have a look at it, and we'll see if it is up, if there is any issues. That will be fine. Ashvin, if you are final year medical student and you don't have MBBS, you can still upload your last year transcript. There are several subscription options. So the most common subscription option you have got is the 599 Australian dollar plus 10% admin and GST. Yeah, so in case of payment, it's an online payment, which means you will need a credit card or debit card, which allow online payment, which will be in dollar. Yes. eMedici, I say that because AMC is suggesting that it's not a bad idea to do the eMedici Q Bank. You can definitely do that. Today's class will be uploaded tomorrow morning. Joining, I'll have a look at that. So why you can't see that? I'll see if I'm making a mistake or not. You don't need to read from anything else because the theory will be discussed in detail. So you will get everything that is needed. So unless I specifically ask you to read something from somewhere, you don't need to read anything else. Yes, so we will upload something after. So we discussed few things during our orientation class after these 2 weeks, how to register for the EPIC or Intel Health, okay, for registration. 15 months. So when you go to the subscription, it will ask you to choose from 4 options. Just read the 15 month, read where the 15-month axis is, then just click on that. I just don't. So why not, Nair? Why you can't complete the balance through the portal? What's the error it's showing? Can you send a message or a screenshot to us? There is no other way to do it if your online card is not getting accepted. Almost every online card will be accepted in the portal because we use a very common payment integration system. So usually everyone who has an online card, it's really nice and easy. It should be fine. Unless if your card does not allow it, then we don't know how to do because you will need a card even to register for AMC. So you can use someone else like a relative who might help you. So there is no other way. We don't have any other way of payment. Yes, we'll tell definitely we'll take which topic to read for the guidelines. The last date for second installment is 6 weeks from when we started the course. Okay. All right, guys. That's it for tonight. Thanks everyone for your active participation and come again in the next class. If you have any more questions, we'll discuss that again. Okay. Thanks all. Have a good night. Take care. Bye.